schedule, Dr. Walsh is going to be the first speaker because he has to head out to the Children's Hospital soon. So, Kevin, please go ahead. So, mic is not on.
Tell me all about this name that is difficult to say. It was given
Mic is not on. And turn the music off, please.
Yep, that's on. Thank you. And can we have the slides, please?
Thank you.
Just to project. Great, thanks. And I'd like to thank Dr. Tin and the organizers for the very kind invitation. And also thanks to being allowed to go first so I can head off to the Children's Hospital. Great, thank you. So my favorite device. So the Ceraflex is an evolution. It started obviously as Heart-R, became Cera, and then became Ceraflex. And the difference with Ceraflex, the flex in it, is the actual string that attaches the device to the delivery cable. In terms of what you get in the box, it's already on the cable, and you've got the loading mechanism, but you have this handle which has a red button to allow you to engage the release mechanism. And this is the way the release system works. You can see as you pull back on this handle, this sort of mandrel comes back, releases the loop in the string, and then allows the loop to come out of the device. That's the profile of it compared to Amplatzer. It's probably a bit lower profile, and you can see there's no hub or post on the left atrial side. Flexibility and stability, these are sort of animations. And you can see it's quite stable, and there's a lot of flexibility in terms of that you really can genuinely assess what the post-release position is going to be like prior to release. In terms of the sizes that are available, it's available from 6 to 32 millimeters. You don't have it in the bigger sizes in terms of 36, 40, 42. You'd have to go back to Cera for those. It also comes in a multi-fenestrated version, which is actually more important because it's often in these multi-fenestrated aneurysms that you want to get enough tension release, pre-release assessment. And an example of the animation compared to the previous device. And I think we're all familiar with this with the Amplatzer. It works very well, but there's always certainly a leap of faith prior to release that it's going to look okay. So in terms of publications or support for it, this is a multi-center Turkish study, 125 patients, 58 Ceraflex, 67 Amplatzer, similar patient characteristics. It worked well in both groups, and the only difference was one transient left atrial hub thrombus in the Amplatzer group. So the flexibility during implantation, do we need it? Felix Berger kindly helped me with the talk. He gave me some of these illustrations, and these are examples. 10-year-old secundum ASD, and if you know Felix and his group, they do these on transesophageal without any fluoro, by and large. They do them completely echo-guided. So this is a 12 millimeter Amplatzer septal occluder. It's checking the device position prior to release. So we're pretty much all familiar with this. And we can see the change in angulation from, you can see it beforehand, and you can see what it's like afterwards on these frames. And the final result, of course, is very good. Another case, small secundum ASD, small aortic rim, small superior rim, balloon sizing, 11 millimeter stop flow, 12 millimeter Amplatzer septal occluder, really didn't align properly, kept coming through. We're all familiar with this buttonholing approach. And third attempt, still not really settling. And Felix is having a problem if he's thinking about these things. And even at this point, he thought maybe he would use radiation to see would that help close it. So you put a 12 millimeter Ceraflex. This is how it settled. Looks nice and flat, and released with just one attempt with that. So that was an interesting comparison, although case by case, and that's after the release. And you can see it doesn't really change position during the release at all, before and post. And this case, which was difficult for them, had 1.2 minutes of fluoro, but so they only use fluoroscopy if they really need to. So another case, 26-year-old, 56 kilos, 3D reconstruction, reasonable defect, 26 to 27 millimeter on sizing, so a 20 millimeter Ceraflex released. You can see the position, looks nice, nice configuration around the aortic root, and this is what it looks like in 3D. 50-year-old, 16 millimeter defect, balloon sizing, stop flow, 21 millimeters. Device opens nicely, 22 millimeter Ceraflex, and a good position, nice and flat. And that's at release with very little change in position. So the German Heart Center was experienced as 14 patients, and these were the range of devices they used. In terms of cases that we've done, my colleague Paula Sleeslock put together our cases last year. I think we did a bit more since then, but there's another little follow-on story with 78 patients up to 18 years, wide range of weights, more females, mostly secundum ASDs, because it's a children's hospital, device size versus weight, TOE size, balloon sizing on most of them, one embolization, and small residual ASD in 3 patients, but we were happy with that. With this device, if you do get a migration, you need to have this tooth-head biopsy forceps. It actually has hooked teeth called a Maslanka forceps to be able to catch, one of the ends depending on the way the device is facing. So, but what did happen with the Ceraflex occluders is they were pulled off the market because of this tulip malformation. I think this was Medtronic's decision. They're now back on the market, and we're just waiting for resupply of them. So to conclude, early experience with Ceraflex, very promising, high occlusion rate, flat configuration, good and flexible implantation characteristics. The position doesn't change after release. Huge advantage in deficient aortic rim, and has a slight disadvantage with a larger sheath. We've no long-term results, and there's always concern about erosion endothelialization. Thank you very much.
Thank you.